Part 3 of Bleeding Tendency lecture. Coagulation defects which may cause bleeding tendency. As we said before, it is either hereditary or acquired. We will start by the hemophilia as an example of congenital bleeding tendency. In this picture, we will see factor 8, which is the cause of hemophilia A, is not working. So, the other coagulation factor will collapse and also will not be functioning. In hemophilia, one clotting factor is missing, or the level of that factor may be low. This will make it difficult for the blood to form a clot, so bleeding will continue longer than usual, not faster. Since there are many clotting factors in the plasma, each factor is named with a Roman numeral. Low factor 8, it's called hemophilia A. Low factor 9, it's hemophilia B. Why hemophilic patients bleed? Why they are bleed longer than other people? They are bleed because there is a factor missing. This missed factor make blood clot not formed in the same potency like in normal persons. Hemophilic patients may be in the category of mild hemophilia, moderate hemophilia, or severe hemophilia. This will depend on the level of clotting factor in his blood. If the clotting factor from 5 to 40%, it is mild hemophilia. If the clotting factor ranging from 1 to 5%, it is moderate. Below 1%, it will be severe hemophilic. Presentation will depend on the percentage and activity of factor 8 in the blood of hemophilic patient. In case of mild hemophilia, usually bleeding occurs either during surgery or due to major trauma. In moderate hemophilia, they will bleed due to mild to moderate trauma. In severe cases, spontaneous bleeding and spontaneous hemoarthrosis, which is the most dangerous and most common complication in case of hemophilia. Is it lifelong or the patient can cure? It is lifelong. A person born with hemophilia will have it for life. The level of factor 8 or factor 9 in his blood usually stays the same throughout his life. In this slide, we see on the left lower limb swollen. This is due to recurrent intra-articular bleeding, either due to trauma or spontaneous in severe cases, and it will end sooner or later by osteoarthritis and fibrosis. Recurrent joint bleeding or hemoarthrosis is the main complication seen in hemophilic patients. Sometimes there is life-threatening bleeding. When the patient bleeds inside the head, intracranial hemorrhage, subarachnoid hemorrhage, bleeding into the throat, gastrointestinal bleeding, it is dangerous and it can threaten his life. Serious but not life-threatening bleeding when the patient bleeds inside the eye, inside the spines, bleeding in muscles, deep muscles, especially psoas muscle. What is the therapy? Is it curable? Yes, we can cure patients by giving replacement, by giving the factor missing. The only mode of treatment is replacement therapy to inject the missing clotting factor into a vein. It cannot be given by mouth. Is there any other line of management in hemophilia? Yes, there is other lines of treatment, but the replacement therapy is the main line of treatment, but the other lines are supportive to replacement. When there is bleeding inside a joint, we have to make the joint rest, do cold compresses. We can give intravenous DDAVP or desmopressin. Sometimes we can give it also by nasal spray. We can give antifibrinolytic as tranexamic acid and cyclocarbon. And if the factor replacement is not available, fresh frozen plasma, cryoprecipitated, factor 7 in severe cases, and prothrombin complex concentrates. All these factors are replacement to the missing clotting factor 8 to help coagulation and to help blood clot to be formed. But the main line of treatment is giving factor 8. Von Willebrand disease. What is von Willebrand factor? A large multimeric glycoprotein circulates in the blood at a concentration of approximately 10 mg per milli. In response to numerous stimuli, von Willebrand factor is released from storage granules in the platelets and in endothelial cells. What is the role of von Willebrand factor? It performs two major roles in hemostasis. First, it mediates the adhesion of platelets to the site of vascular injury. Second, it binds and stabilizes the procoagulant protein factor 8. Clinical features of von Willebrand disease. Von Willebrand disease may be mild or moderate or severe. Mild cases usually asymptomatic, present as mild mucosal and cutaneous bleeding, easy bruising, epistaxis, or menorrhagia. Moderate to severe cases usually present by the above bleeding tendency, but in a more severe condition. Occasionally, soft tissue hematomas may be formed. Sometimes, when there is low platelets, petechiae and purpura may be found, especially in type 2 von Willebrand. Gastrointestinal bleeding, hemoarthrosis can happen. Male and females are affected equally. However, the phenotype may be more pronounced in females because of menorrhagia and the greater visibility of bruises. In the great majority of cases, von Willebrand is an inherited condition. Bleeding-related symptoms may occur at a young age, even just after or during birth. Von Willebrand is divided into three major categories: partial quantitative deficiency, type 1, and is mild; qualitative deficiency, type 2, it is mild to severe according; total deficiency, type 3, and it is severe presentation of von Willebrand disease. Type 2 von Willebrand disease is divided into four variants: A, B, N, and M, based on characteristic of dysfunction von Willebrand factor. For most affected individuals, von Willebrand disease is a mild manageable bleeding disorder in which clinically severe hemorrhage manifests only in face of trauma or invasive procedures. In individuals with von Willebrand disease type 2 and type 3, bleeding episodes may be severe and potentially life-threatening. Individuals with type 3 disease who have correspondingly low factor VIII levels may develop arthropathies, as more commonly seen in hemophilia A, patients with comparably decreased factor VIII levels. Von Willebrand level normally increase with age. This means that most cases improve by age. Von Willebrand disease may be acquired. Acquired von Willebrand disease is a rare disorder that results from the development of antibodies against von Willebrand factor. Acquired von Willebrand disease may arise from a variety of mechanisms and typically resolves with the treatment of the cause. For example, acquired von Willebrand disease may occur in patients with hypothyroidism. These cases are typically mild to moderate and improve with restoration of euthyroidism. Acquired von Willebrand disease has also been reported as a cause of post-operative bleeding in patients with congenital heart disease, especially those with complex defects. Investigations. Investigation of a bleeding patient. We have to do prothrombin time, activated partial thromboplastin time. If we suspect factor deficiency, we may ask measuring the level of this factor. If we suspect factor VIII, we have to measure factor VIII coagulant activity. Sometimes, if we suspect a platelet factor defect, we have to do platelet function test like ristocytine cofactor activity. Concentration of von Willebrand factor or von Willebrand antigen also may be asked for if we are suspecting von Willebrand disease. Recessively inherited coagulation factor defects. These defects may happen and there is patient with bleeding tendency and it is not factor 8 or 9 or von Willebrand, and the bleeding due to a rare condition like in fibrinogen deficiency, prothrombin deficiency, factor 5 deficiency, factor 7, factor 10, 11, 13, any factor can be deficient and cause in bleeding tendency. DIC or disseminated intravascular coagulopathy as an example of acquired coagulation defect. Definition: it is uncontrolled release of plasmin and thrombin leading to intravascular coagulation and depletion of platelets and coagulation factors and fibrinogen, which result in life-threatening hemorrhage. What is the etiology? Usually DIC occur as a complication of many other conditions, especially severe condition with widespread endothelial damage or extensive inflammatory cytokine release. In this slide, why DIC occur or when DIC occur. It occurs if there is severe acidosis, severe hypothermia, severe dilution, hemodilution in multi-traumatized patients. All these severe conditions will lead to, by the end, to a DIC or disseminated intravascular coagulopathy, and sometimes we call it consumption coagulopathy. Etiological causes of DIC. OMITS, omits. This O for obstetric complications, M malignancy, I infection, T trauma, S shock. Any condition any one of these conditions can lead to DIC. What is the clinical features of disseminated intravascular coagulopathy? DIC characterized by the presence of both hemorrhage and clotting. Usually microvascular thrombosis, which usually manifest as multifocal infarcts, delirium, coma, seizures. In the skin, we may find focal ischemia, superficial gangrene, oliguria, azotemia, cortical necrosis, ARDS or acute ulceration, microangiopathic hemolysis. Hemorrhagic manifestation, bleeding from any site in the body, intracranial hemorrhage, skin petechiectasis oozing from puncture sites or surgical sutures, hematuria, gingival oozing, epistaxis, massive bleeding. These all together may be found in patients with DIC. So we can see a thrombotic manifestation. At the same time, we may see hemorrhagic manifestation. That's why it is a severe condition, and it is also a life-threatening condition. How we investigate a patient with DIC? CBC, sure, to see the platelet count, decreased platelet count. Secondary hemostasis by doing prothrombin time, activated partial thromboplastin time, thrombin time. We may find also fibrinogen decrease in any other factor. We can find, and it is characteristic and diagnostic, increased FDBs, fibrin degradation products, D-dimer, extent of fibrin deposition. We may find urine output decreased, urea and RBCs fragmentation and schistocyte. Treatment. Recognize early and treat underlying disorder. First, we have to treat the precipitating cause. So, treatment of DIC means treatment of the primary. If the patient is bleeding, we have to stop bleeding. If the patient is multi-traumatized, treat the trauma. If the patient is in septicemia, you have to treat the septicemia. In hemorrhage, replacement of hemostatic element with platelet transfusion or frozen plasma or cryoprecipitate. Usually we like to maintain platelet count above 50 and the hemoglobin above 8 by replacement, sure. 4 to 5 units of fresh plasma if the INR more than 1.5 or the ABTT more than 338. 10 units of cryoprecipitate if the fibrinogen is below 100. In thrombotic phase, we have to use unfractionated heparin or low molecular weight heparin in critically ill non-bleeding patients. Vitamin K deficiency as a cause of acquired coagulation defect. What causes vitamin K deficiency? may be due to drugs, oral anticoagulant, which inhibit factor 2, 7, 9, and 10. Also may inhibit protein C and protein S. Antibiotic eradicating gut flora, altering vitamin K uptake. Poor diet, especially in alcoholics. Biliary obstruction, chronic liver disease, malabsorption as in celiac disease, hemorrhagic disease of the newborn. Investigation, INR and BT, usually prolonged out of proportion to elevation of the ABTT. Decreased factor 2, 7, 9, or 10, which are the vitamin K dependent factors, if we measure it in the plasma. Treatment of vitamin K deficiency. First, we have to hold anticoagulant, vitamin K replacement orally or by injection. If life-threatening bleeding and vitamin K antagonists, we can give frozen plasma or prothrombin complex, and this is in severe cases. This table shows lab values in this order of hemostasis. In different cases, PT, PTT, platelet count, RBCs count, in different conditions. Prothrombin time. Prothrombin time measures the extrinsic pathway factors, especially factor 7 and common pathway. It is prolonged in case of factor 7 deficiency, liver disease, oral anticoagulants. INR, international normalizing ratio, usually ranging from 0.9 to 1.2, and it is used to monitor oral anticoagulant warfarin. Activated partial thromboplastin time, normal value from 22 to 35 seconds. It measures intrinsic pathway factor 8, 9, 11, or 12, and the common pathway, used to monitor heparin therapy and intrinsic pathway factor, usually prolonged in hemophilias, either A or B, heparin therapy, DIC. At last, checking bleeding profile is an important issue for every practitioner, whatever his specialty. Thank you.